Members of the symposium, welcome again to our symposium in this month of March, and thank you very much for registering and setting aside time to participate in today's symposium. As we have seen today, we are very lucky to have pharmacist Mujahidhussein Valji, who is a chief pharmacist at the Aga Khan Health Services Tanzania, and including the Aga Khan Hospital in Dar es Salaam. Short introduction: Mr. Mujahid is a pharmacist who graduated from the Muhimbili University of Health and Allied Sciences with a Bachelor of Pharmacy in the year 2007. And then he studied in the Queen's University Belfast in the UK, and graduated with a Master of Science in Clinical Pharmacy in the year 2014. He has been working with the Aga Khan Hospital in Dar es Salaam for more than 13 years. And he's also a member of the International Pharmaceutical Federation, where he's coordinating the hospital pharmacy affairs in the African region. Mujahid is also a member of the Pharmaceutical Society of Tanzania, the Education, Research, and the Publication Committee. And Mr. Mujahid, you are very welcome to proceed with the presentation.
Thank you, Nelson. First of all, I'd like to thank you for giving me this opportunity to showcase whatever little that we have been able to manage to achieve during this time. Apologies to the participants for the slight delay due to the IT hiccup. But without wasting much of your time, we'll start off the topic, and I think I have the bullet points with me and some pictorials of what we are going to discuss, and then I'll leave this floor open to discussion, and we can always have more input from other participants. So as has been shared earlier, the topic for tonight's for today's discussion is pioneering state-of-the-art hospital pharmacy practice in East Africa. Experiences of Aga Khan Hospital, Dar es Salaam, Tanzania. I don't know if it's state of the art, but we have achieved somewhat. So as time goes by, we will see what we can and what we can share for others to implement. Okay, what I'm going to cover today is introduction to hospital pharmacy, a very brief introduction to what hospital pharmacy is all about, then some of the achievements and when they were achieved during the course of the last 13 years or so since I joined. Thereafter, what are the current processes that we would propose based on what we are practicing at present, that would make hospital pharmacy practice optimal. Then how can we use technology, right? Technology and staff enhancement to better patient outcomes, and what do we envision or what do we plan to achieve in the future based on the challenges that we are facing at present. So a brief introduction to what hospital pharmacy is all about. Hospital pharmacy is a healthcare service which comprises the art, practice, and profession of choosing, preparing, storing, compounding, and dispensing medications or medical devices, and also advising patients, doctors, nurses, and other healthcare professionals on their safe and effective and efficient use. It is very important to note here, it is not just compounding and dispensing, it is choosing, preparing, storing, right? And as we see further, what does choosing mean? We'll look into what does choosing actually mean. So it's a very wide, it's not just dispensing and that we are used to, but it's more than that. More so is the issue of advising. And whom do we advise? Not only patients, but doctors, nurses, and other healthcare professionals as well. It's a very specialized field of pharmacy, integrated part of patient healthcare in a health facility. It's a multidisciplinary, I mean, we have to be part of the multidisciplinary team that works in an integrated manner for a patient, for a better patient outcome. And it also entails continuously improving our medication management and pharmaceutical care of patients to the highest standards in a hospital setting. And this has to be evidence-based, right? So whatever that what we are practicing has to have some evidence as for the current research and findings. So what should be our mission as hospital pharmacists? To be part, number one, to be part of the medication management in hospitals, which encompasses the entire way to which medicines are selected, procured, delivered, prescribed, administered. So before administration is after being prescribed, how do we dispense it? How do we process it? And reviewed to optimize the contribution that medicine make to producing informed and desired outcomes. Also to enhance the safety and quality of all medicines related processes affecting patients of the hospital to ensure the 7 R's, right? We are used to the 5 R's, the right patient, right dose, right route, right time, right drug, but we even have the right information and right documentation, which also has to be taken into consideration. And this has to be all the way from doctors all the way to the nurses, and in between are the pharmacists, whereby we ensure that all the R's are being adhered to. Okay, so some of the important timelines and achievements that we have achieved at Aga Khan Hospital. I began my career at this esteemed institute in 2008, and I must say that all the things that followed thereafter. When I joined, I was under at that time the chief pharmacist was the late Fayaz Muhammad Taki, those of you who know him, and he had been a very good mentor, and many of the things that we have achieved and are achieving till now are due to the basis and strong team and mentoring that he has done to all of us. So when I joined in 2008, soon after completion of my internship at MUX at that time, and then it was converted into a university, MUHAS, as it is called now. So 2008 is where I started. 2009, we were the first private hospital to be selected as an internship center. So we started receiving some interns, pharmacy interns, whom we were training for a year. At that same year, we started going into some clinicals whereby we were doing ICU ward round, although not very officially, but at least we started getting the practice of how we need to work ourselves clinically. In the same year, we initiated the CPOE inpatient. For our inpatients, we initiated the inpatient computerized physician order entry, whereby all our inpatient orders for pharmacy orders were coming through the electronic system. In 2010, so prior to this, we were ISO certified, but then the hospital management and the board thought that let's go a step further and let's start our journey into applying for the Joint Commission Accreditation International, JCIA. This is a more specific accreditation standard that is more so for the health industry, especially for the hospitals. So it was a long journey, and it required a lot of trainings, a lot of efforts, and that's where our journey started in 2010. In that process, we have learned a lot, and although PNT committee was there, we were required to strengthen it as part of the JCIA requirement. In that same year, one of the learnings that we had is we need to have a unique drug dispensing system. Although what we started off with is a 24 hours dispensing. What it means is we used to dispense drugs for the next 24 hours for inpatients, right? So whatever is required, for example, if a patient requires paracetamol IV Q8 or every 8 hours, we would give only 3. Okay, he might require for 5 days, but we would only give 3. Come the next day, we would supply another 3 until the patient is discharged, right? Or the drug is discontinued. In 2011, we had the first clinical pharmacist, a graduate from our hospital who was undergoing this training with Queen's University. Okay, that was in 2011. Then in 2014, we had our oncology program established in the hospital. So we were part of it because pharmacy plays a vital role in the sense that we need to be part of the clinical team that reviews the orders, Thereafter, the admixture, which is very specialized, and we undertook that as well, and we established the sterile unit for the oncology drugs, whereby we had the pharmacy isolator, which we'll see later, and even the training. I was fortunate to undergo this training and establish this program in our hospital. The same year, we had the second clinical pharmacist. So in 2011, we had the first, and then we had the second clinical pharmacist graduated from. So now by 2014, we had 2 clinical pharmacists for our institute. In 2015, we established a sterile admixture for high alert medications and antibiotics. So in 2014, we had the sterile admixture unit for oncology drugs only, which was separate, right? Then we established for other drugs as well, which included antibiotics and high alert medications. The same year, we established the antibiotic stewardship committee with terms of reference, and we had a pharmacist who was undergoing a training by the Society of Infectious Disease Pharmacists on this ASP training. Okay, so this all was to enhance and ready ourselves for the JCI accreditation. Come 2016, we had the JCI first accreditation survey, and we were lucky enough and we achieved it on our first attempt. Come 2017, we had medicine reconciliation during bin exchange implemented. This is whereby when we do the bin exchange every day to every ward, the reconciliation is done between the pharmacy or pharmacy staff and the nurse, ensuring that all drugs are supplied as per the order of the doctors. So as to avoid errors during the night or subsequently, so that the patient does not miss any dose. Thereafter, we had outpatient CPOE implementation completed. So as we saw in 2008 or 2009 rather, we had the inpatient computerized physician order completed. Then by 2017, we even extended it to our outpatient. So even our outpatient, our electronic, the doctor would send his order, his or her order through the system, and we would receive it through the system. This CPOE is very helpful in the sense that first of all, we get the records very easily. So that to get the records, it's easy to access the records. Second, it even reduces error, right? Transcribing error or reading the prescription. So it makes the less chances of medication error if we use the CPOE system. In 2018, we initiated medicine reconciliation on admission, whereby any patient who's admitted into our inpatient, we do a medicine reconciliation to have a continuity of care. So that the patient continues taking whatever chronic or other medications, for example, antibiotics, that they were supposed to continue whilst being admitted. In 2019, we had our new inpatient pharmacy, where we relocated to a new state-of-the-art inpatient pharmacy, whereby we had a better system, and one of them being the pneumatic tube system for sending drugs, especially stat drugs, in a timely manner. In the same year, we had our JCI re-accreditation, whereby we passed. In 2020, we had the COVID, right? So the COVID hit us, and so COVID itself had its challenge, right? So one of the challenge was consistent supply of drugs, especially the remdesivir, the tocilizumab, and other drugs as well, because the supply was limited due to the transport and other logistics measures. So we battled it with our procurement team and ensured that drugs like toci, which were not registered in the country, were brought in through the support of TMD and the regulatory bodies. We initiated, because now patients were afraid to come to the hospital, and especially those who are on chronic medication. So we initiated the home delivery of medications. Later on in 2020, we started a vaccination center, a dedicated vaccination center, whereby someone can go and go to the vaccination center, get their vaccines without moving from pharmacy to an administration area. So all under a nurse was trained and supervised by the pharmacy department. Last year, we had another pharmacist undergoing, who underwent the ASP training, who is still undergoing the training, again by Society of Infectious Disease Pharmacists. And we even had, when the government rolled out the COVID vaccination, Aga Khan was one of the sites which did quite a number of, around more than 15,000 vaccinations, right, so far, and we are still continuing to do it. Again, it was under the umbrella of the pharmacy department, and we did both in-house and outreach of vaccinations, COVID vaccinations. This year, we are now piloting. Yes, we have a pharmacist going for ward rounds in ICU, but now we even want to extend it further and have a pharmacist spend more time in the wards. So we have piloted in few wards, whereby we want the pharmacist now to take a lead in the pharmaceutical care management of each and every patient who's admitted in the hospital. Okay, having discussed that, what are the current processes that are essential for a hospital pharmacy? So these are the bullet points that we have, and I'll be discussing them. And later on, we'll be seeing some of the pictorials and some of the pictures of how this look like. And this is a plan whereby you see the whole process of medication management starts from planning up to evaluation. So first comes planning, thereafter how do we select and procure medications? Thereafter, how do we store the medications that have been procured? How are those medications ordered, right? How does a doctor order medications? Thereafter, how are they prepared and dispensed in pharmacy by pharmacy? Followed by administration by the nurses, monitoring thereafter, and medication error and adverse event reporting, and finally evaluation, right? So these are all the steps that are very essential for a hospital pharmacy to keep in mind, so as to have an efficient or effective pharmacy system in place. And pharmacy is a very integral part of the health system of any hospital, because almost every department rely on us for their effective outcomes or systems and their processes. So we have to have a very efficient system and work hand in hand with all of the departments to ensure that they work appropriately as well. So first comes planning, right? And this has been adopted from the JCIA standard of MMU, Medication Management and Use. Okay, so in planning, we mean how are we planning our medication management and use, which is the cornerstone is a pharmacy and therapeutics committee, which entails it's a multidisciplinary committee which consists of doctors, pharmacists, nurses, dietitians, radiologists, whoever else, right? Whoever else who is dealing with medications, and the procurement team. So all of them make up this committee, which meets, in our case, every quarter, at least once a quarter. We have our terms of reference. We have our some agendas like seeing the key performance indicators and the likes. So this committee is what oversees the whole process of medication management, and pharmacy is a very integral part of this committee. Another plan in planning is very important to have an ASP committee, Antibiotic Stewardship Program Committee, which oversees the use of antibiotics. And this also came about due to JCI requirement when the new edition in 2016 was released. ASP was a mandatory to have it as in our hospital. So we were given that motivation But apart from that, it really gives a good control over the use of antibiotics in the hospital. And as we know, ASP, antibiotic resistance is a crisis now. We don't have many new antibiotics coming up in the recent past. So we need to be very, very careful about our use of antibiotics. Rational use of antibiotics is very essential. There's another committee where pharmacy and pharmacists play a very vital role, and they are the ones who run these two committees. Apart from that, we are even part of many other committees like infectious control, product review, and many other such committees where a pharmacist's role is very essential. Another thing very important in planning is we need to have our key performance indicators, right? How are we going to monitor ourselves? So like for us, we have our stockouts, zero balance against the formulary. We have medication error. We have near miss. We have adverse drug reactions. So these are some of our key performance indicators that we have. Right? For ASP, we have things like rational use of antibiotics. So these are the things that we need to monitor and report on a periodic basis, be it quarterly, be it once a month, whatever works out for any organization. But that will tell us, and these key performance indicators need to have a benchmark, right? So we said that, for example, our zero balance against formulary, our stockouts should be less than 1%. Then we need to monitor, are we really adhering to it? Are our stockouts really less than 1%? If not, then why? And what needs to be done? So key performance indicator is a very important tool for monitoring the progress of our activities. Then comes selection and procurement, right? How are new drugs made part of the formulary? Okay, we have so many drugs and many drugs are being registered as time go by. And we have so many pharmaceutical companies, they would come and tell us, please stock, we have this new drug. So there has to be a scientific way of deciding what fits our institute, what do we need and what do we not need, because we can't just be increasing our inventory. Based on the needs of the clinicians, our services, whatever our clinicians require, our scope of service is what guides this selection. It is very important, and pharmacists play a vital role in that. Yes, the procurement will be done by the procurement team, but the guidance and the approval needs to come from the pharmacy department, and not the pharmacy department alone. It is the MMU, right? The PNT committee, which sits and deliberates on all this scientific evidence and the need of the institute. And it even entails, procurement even entails that we abide by the regulations of the country. So like we procure registered drugs, we procure from reliable resources, we go and on timely basis monitor our suppliers. Are they storing, are they abiding, how is the storage, how is their purchasing, for example, for cold chain items, you would request them for few cold chain items, you would request for the cold data log, right? How has since on the point of manufacturing of the drug till when it was supplied to us, please show us proof that the drug was maintained within that 2 to 8 degrees, right? And this is what we requested when we were importing remdesivir, right? So one of the suppliers was asked to give proof of maintenance of temperature, right? So those are the things that are very important in procurement, so that we know what we are giving our patients is something genuine, right? Something that is reliable. Very important that is our job to ensure that the drugs are of good quality. Then thereafter, once you have procured, is storage. So how are we monitoring our temperature and humidity logs in different areas, be it the pharmacy, be it the medication rooms in the wards, be it our sterile unit where we do our admixtures. So all these storage things need to come into place. Auxiliary labels as well, right? So we have those drugs which require refrigerate, you would put a refrigerated sticker. and the likes. A random stock take. So storage even requires inventory management. Because as pharmacists, we need to ensure that drugs are controlled against pilferage or against any variants. So that's another aspect that we need to look into. So one of the ways is running random stock takes. Thereafter comes the ordering. How do doctors order drugs, right? So we have alert and prompts in our system. We have high alert medications, right? So these are drugs which are, we have categorized them, the certain classes of drugs which, if not used appropriately, can have an adverse outcomes. So that's why we require a very high degree of, we have to be very careful prior to prescribing, prior to dispensing, and prior to administering. So it goes to all levels, from the doctors to the nurses, okay? That we need to ensure that we are double checking prior to carrying out the final step. Then it is even so, as a pharmacy department, as PNT, we have to continuously educate doctors on pharmaceutical care plan, on new drugs, on how to report adverse events or medication errors and the likes, right? So that's where we come in. So here even an aspect of ASP. I haven't touched a lot on ASP, on antibiotic stewardship, but that a lot on itself is a whole topic of its own. But here even it's very important. We have a system of restricted antibiotics. We have certain antibiotics, broad spectrum, which are used for conditions which are not when we do the culture sensitivity, they're sensitive, they're resistant to the first line, second line. Then we go to these broad spectrum antibiotics. We call them life-saving antibiotics, especially for sepsis and those types of conditions. So once after ordering comes preparing and dispensing. So here comes, we have a sterile admixture unit for oncology and antibiotics and high alert medications. We have a 3-check system. So how do we ensure or reduce medication error? So we have one person processing the orders from the doctors, the other person packs it and labels it appropriately, and the third person checks it before finally sending it to the ward. So 3 different people doing the check system to reduce medication errors. And this was a learning that we got when we did our RCA, early on, when we had some medication errors. We said, how do we reduce it? So we came about this system, where let us have a 3-check system to reduce medication errors. Appropriateness review, and this is what I call is the most important policy that pharmacists need to know. Okay, everything else, yes, the storage, the planning is very important, but we as clinicians, if we want to practice our profession as clinicians, this is where we come in. And we will see this appropriateness review later on. What are the parameters before we dispense a drug? What are the parameters that we need to go through before we send the drugs to the wards? Labels, patient-specific labels are what we after processing the drug, we take out the labels which are patient-specific and instructions on how to use the dose, the frequency, the duration, and any other condition that is relevant for that patient or that drug. Then also reconciliation. So as I said, we have a medicine reconciliation on admission. Prior to admission, on admission of any new patient in inpatient, we do medicine reconciliation. So that even forms part of our dispensing. Prior to our dispensing of drug, we ensure that there's continuity of care. In administration, we ensure it's, now here is a nursing part, but we do our nursing education. We ensure that they are timely administering the drugs and giving the appropriate information to the patients prior to every administration. In monitoring, there is the pharmaceutical care management or plan, whereby we ensure that those patients, especially those who are admitted, they are monitored for the effects of the drugs. They are, and for any other adverse events. So for example, those who are taking, for those who are on concentrated electrolytes, right? So we would ensure that they are monitored for the, for example, if someone has hypokalemia, okay, and if we give potassium, then we would be monitoring the potassium level on daily basis, right? In that way, even for analgesics, are they responding to pain, to the pain management, right? Are they doing to the drugs, and so on and so forth. Yes, even for antibiotics, how are they responding? Okay, so that is a whole patient care management, and that is on patient specific. But when we go on general, we have our crash cards, we have our ward stocks. The pharmacy takes a lead in monitoring them, that the drugs, we have the appropriate drugs at the level that we have agreed upon. The narcotics come in, very important, that the narcotics are always as per the requirement and the regulatory requirements. We even have ward stocks, right? So there are some drugs that are kept in the ward, and in in certain cases where they cannot wait for the drugs to come from pharmacy, so we keep a few ward stocks, like for analgesics and other such medications, and in like IV fluids. So they start in certain cases, the patients are started on these drugs using the ward stock, waiting for pharmacy to send the drugs after having reviewed the POE, right? So this is on very rare cases. So we even have the ward stocks that are kept in the ward. So that also is under the custodian of the P&T committee and pharmacy in particular. Thereafter comes medication error and adverse event reporting. Again, a very important part we have to monitor, right? We know medication errors, yes, we have to have a very good system, but we know systems sometimes can fail, right? And medication errors are going to happen, right? We have seen throughout the world. They do happen, but we need to learn from them. So we need to monitor them. Whenever they are done, we capture them, and then we do a root cause analysis. So we have a system whereby we report the, for example, if a nurse picks up a dispensing error from pharmacy, okay? So that would be a near miss, right? So they would report it in the system, and we would be required to do an RCA. Why did it happen and how did it happen? Was it a system error? Does the system need to be changed? Or is it something to do with maybe something, you know, it was an overlook, the policy is there, the system is there, or maybe the staff overlooked it, right? So we need to look into, we do the RCA whenever there is any medication error, or there's any adverse drug reaction or adverse event. So all these need to be reported, and if there's any adverse drug reaction, particular to a drug, or any such reporting that is related to a specific drug, then we even need to report it to the regulatory authority, which is TMDA. Then comes evaluation. So now evaluation is when we have our committee meetings, PNT, maybe it's PNT meaning pharmacy and therapeutics, when we have the antibiotic stewardship or any other. We need to yearly or quarterly review of our system, right? Be it our medication errors, be it our out of stocks, be it our near misses, interventions, pharmacy intervention, our formulary review, right? So all these things need to be reviewed and evaluated. So like we review annually our formulary, our KPIs are reviewed. So all these things are happening on under evaluation, which needs to be documented as well. So this is a nutshell of the processes that happen in our pharmacy and in our hospital. Now I'll take you through some slides whereby we show you. We have taken some pictorials of the equipments and the processes, some forms, some TOR that we use, which will better, make you understand what we do here. So this is a PNT, TOR and composition, right? So you see on your left-hand side is TOR. You need to have a terms of reference. What is Pharmacy and Therapeutics Committee going to do? What are the members supposed to do, right? So this is it, right? So these are the functions. So that, like, one of them being advising medical, administrative, and pharmacy department on drug-related issues, developing policies, evaluating and selecting drugs, okay, for formulary and the likes, right? So I'm just giving you a snapshot of what you need to, what should be the terms of reference of P&T committee. And on your right hand side, you'll see what is the composition, right? So you'll see it's a multidisciplinary committee from the chairperson being a physician, senior physician, chief pharmacist being the executive secretary. Then we have all departments being represented, dietitian, pathology, radiology, all of them are represented in this committee. How are new drugs? As we say, there's a process of introducing a new drug. So if a clinician wants a new drug, or even if pharmacy, if as a chief pharmacist, I see that there is a scope for a new drug to be introduced, we need to fill in this form, right? Which asks for the generic name, the therapeutic use, and reason. When you say the reason, we need to give supporting evidence, right? So, for example, if we want to introduce a new NSAID, and we already have existing NSAIDs available, what value is this new NSAID going to add, right? This form is sent to pharmacy, and then in the P&T committee, so pharmacy does its own research on evidence, whatever evidence has been given, and further evidence, cost analysis, the need, the scope of service. They give their findings, and then in the P&T committee, we sit and deliberate and come up with a decision. Yes, we want to include it or not. Then we inform the requesting clinician accordingly. This is an example of humidity monitoring chart, right? That we use for monitoring humidity. So currently we are manual, but this is how we do it, and this is how we chart it. So we chart every day or every day twice. One staff is supposed to go and chart this humidity. So this is a humidity chart. We have similarly a temperature chart, room temperature and refrigerator temperature, whereby this is the temperature and humidity is charted. These are the auxiliary levels, right? You see like high alert, double check, refrigerate, must be diluted, and the likes, right? So these are some of the auxiliary levels that we use, and we put in each and every drug. Okay, so better to enhance and reduce medication error or storage or whatever. It's just a reminder to the staff, be it pharmacy or a nursing staff, about a particular storage condition or class of drugs, so that appropriate measures can be taken. Okay, these are some of the prompts that we have on our electronic system, the current electronic system that we have. So this is the pharmacy system. So whenever when we are processing, so for example, when we are processing a heparin order, heparin is a high alert medication. It would give us a prompt that the screen would turn red, and it would give us a prompt that is a high alert medication, double check before processing. Okay, the same would happen for the doctors. When they are ordering the drugs from the inpatient, they would even see this prompt that please double check. This is a high alert medication. Please be sure of what you are ordering. Okay, so these are the prompts that we have in our current electronic module. This is high alert medications. So this is sort of a reminder that we have put in all the wards in pharmacy that reminds the clinicians, the nurses, the pharmacists that these are the high alert medications which you have to be careful about. So they include narcotics, concentrated electrolytes, anticoagulants, thrombolytics, chemotherapeutics, look-alike, sound-alike medications, insulins, and neuromuscular blocking agents. Right. So these are the prompts that these are the reminders, the flyers that we put on in the wards, so as to remind all on this class of drugs. Our sterile admixture unit. So on the left is our sterile admixture unit for drugs like antibiotics and chemotherapeutics. On the right is a pharmacy isolator that we use for our oncology admixture. As you will see, the difference is this is a very close. The IsoClean or the isolator is a very closed unit, so as to enhance the safety of the personnel doing the oncology admixture, right? In here, you are completely, our contact with the drug is through the gloves, right? So we have a glove box whereby we put our hands and we do the admixture. It's a positive, negative. So that means when the window that you see on the right hand side of the isoclean, when we open, it is negative to the air, to the outside air. So whatever the air goes into it, this is done so as to ensure that the fumes, the chemotherapeutics drugs, even fumes or whatever that volatile does not reach the pharmaceutical personnel. Rather, there's a chimney and there is a HEPA filter, and it is blown out of through a special chimney which is connected to the isoclean. So this is the protective measure that we take for the pharmaceutical personnel. At the same time, it's an aseptic environment. We ensure that the drugs are admixtured under clean conditions for the patient safety. Appropriateness review. As I said, whenever there are new interns, new trainees, whoever new staff are there or a new staff, I always tell them this is something that you need to know. And this is something which is the most important policy that I believe for a pharmacist. Why? Because this is where our clinical practice is all based on. It is a policy whereby we, prior to every reviewing of a prescription, be it outpatient or inpatient, we need to ensure that these parameters from A to G are adhered to. So we need to make sure that the selection of drug, frequency, and route is correct. So how do we ensure that? So we would be seeing the diagnosis, the weight, or other condition of the patient, right? The sex, the gender, and the likes. So based on that, we would be ensuring, is this the correct drug for this patient? Okay. Thereafter, the therapeutic duplication. Is there a duplication? Are we ordering the same class of, let's say, analgesics or antibiotics, right? To cephalosporins or similar cephalosporins or the like. So there, we need to be ensure that we are not doing a therapeutic duplication. Any allergies or sensitivities. So whenever our orders come, there is an area of allergy whereby we show us what is the patient allergic to. Then we need to cross check. If the patient ordered has the patient been ordered that drug or any similar drug in that class, so that we are not giving out any allergic drug that the patient is potentially allergic to. Thereafter is any interaction, drug food or drug interaction. So in this case, we have kept resources readily available for our staff, and whereby they can go and easily search. So if there's a polypharmacy and we know that there's a possible chances of interaction, for example, for ICU, medical, and such patients, we can run a drug interaction checkers. We have the online resources easily available through UpToDate, Medscape. Okay, so that we can run the interaction and ensure that there are no interaction. If any, we report it to the clinician. Then variation from hospital criteria for use. For example, chemotherapeutics is only restricted for the oncologist. So you would not expect any other, for example, like a gynecologist or someone else to order a chemotherapeutic, right? In such as we have some certain drugs that are restricted to certain specialty. That is, we ensure that is adhered to. Patient's weight and other physiological information. This is especially applicable for pediatrics and other, let's say, patients who have CKD or kidney renal insufficiency and the likes, right? So we would be taking extra care and ensuring their dosing and choice of drug is appropriate, or any other contraindication. So this is a very important policy that we teach each and every person, and whoever is processing any order from a doctor needs to be competent with these policies. Otherwise, we do not allow them to process any order from a clinician. This is a patient-specific label. So we have cut off the MR number and the name due to confidentiality, but this is how it would look like, right? The drug name, the route, the dose, frequency, duration, and quantity dispensed, and the time dispensed, and there's even space to writing any other information that is required. So if there is any specific instruction that is to be given to the patient or related to this drug, it would appear on this label. So this is something that we do explain the patients, but we know once the patients are at home, they might forget. So this label would remind them that this is how they need to take the drug. This is the medicine reconciliation and admission. So this is a pre-admission medication list, a sample of how we would do. So every patient who is admitted within 24 hours, we ensure a pharmaceutical staff, a technician or a pharmacist would go and talk to the patient and get the information on what medications they are on prior to getting admitted. So like in this particular example, this patient is on aspirin, insulin glargine, and metformin. And this is the dose, the route, and frequency. Okay, so once we have established this from the patient, we would go to our inpatient orders that we got from the doctor, then you would see, has it been ordered or not? Okay, so if it has been, first of all, we need to check, do they need to continue in the hospital or not? So if they need to, then we need to ensure they are part of the their daily orders. If not for any reason, then if it's kept on hold, then we ensure that it is not part of the order. Okay, so this is what we do on daily basis for every newly admitted patient. Okay, so this is a sample form. This is our medication trolley, right? This is where, as I said, we do unit dosing dispensing, whereby our unit dosing is for every 24 hours. So this is what we would, this is a trolley that stays in the ward, in the medication room, but come, let's say every day at 12 o'clock, they are brought down to the pharmacy, and we replenish the drug based on the orders that we have received for that day. So as you go and see, there are cassettes. So they are around how many? 1, 2, 3, 4, 5, 6. So they are around 20 or so, 20 plus around, I would say around 30 large and small size cassettes for this for the patients, and we would label them. So here we haven't labeled them because we are still putting up the drug, but each and every cassette would be labeled by the patient name and MR number. So and then thereafter, when all the drugs for the medical ward have been packed, they would be sent to medical ward, and the nurse, if a nurse wants a drug for patient X, she would read the name, MR number, and accordingly get the drugs from this medication trolley. This enhances that there is any unused drug is taken back into pharmacy and returned, unless it's a multi-dose vial, a multi-dose a container, which is then resent, for example, for a syrup or a cream, then we need to resend it to be, and if it needs to be continued, it is continued on for the next 24 hours or until discharge. Okay, so this is how we distribute drugs to the wards on daily basis. This is our pneumatic tube system. This we use it for our stat orders. Stat meaning a drug that needs to be given within 30 minutes. So as you can see, whenever the drugs are ready, they are packed into the capsules. As you can see, one of them, which is labeled Pharmacy 34. And we would send it, put it in the tube, and every ward has its own number. So you would send it to the specific ward, and the drug would, within a minute or so, would reach the nursing station, and the nurse would take the drugs and administer it to the patient with the administration sheet. So once the nurse is used, as you see on the bottom, there is that carriage or that place where once the nurses are done, they return it back to pharmacy, and when we store it here, so that we can send other drugs as the orders come by. Okay, having looked into the aspects of our hospital pharmacy, then we would like to look into how are we using technology and and staff enhancement. Okay, so use of technology and staff enhancement. So how do you do it in our setting? Number one is, as we just saw, the pneumatic tube system. It really enhances timely delivery of drugs to different wards, especially as the hospital is growing. So are the wards are further apart from pharmacy, so it becomes much more convenient to send the state order drugs. Our CPOE for drug ordering and dispensing, as we are all electronic, be it inpatient and outpatient. So yes, we have a good CPOE system, but still one thing that we lack is the CDS, the clinical decision support, whereby we have, there are systems like Meditech and the likes, whereby at the point of response, processing or sending an order, they would tell you the drug allergy automatically, they would tell you the interactions automatically, they would give you the lab, necessary lab value, all integrated into one system. So that is something that you are working towards, and in the next 2 to 3 years, you'll be having that state-of-the-art electronic health record system as well. Medication trolley for routine drug distribution, as I showed you. Medication label for patient education, we saw that as well. Use of biological safety cabinets for sterile admixture, that also we saw how they look like. And automated temperature and humidity system with alert from that. So that is something that we are looking on. Currently, we are monitoring the temperature and humidity, but that's done manually. But we want to move towards an automated system, so that in that way, even at night, for example, for a unit that is closed, if there is any fluctuation in the temperature or humidity, there is an automatic alert sent to the head of department or in charge in that unit, so they can take appropriate actions immediately. Staff, we at our hospital institute, we recognize staff are an integral part of the team. Any success and for better patient outcome, the staff need to be well oriented. They need to have a good working environment, and then they need to be very much competent. So how do we ensure that? Number one is our recruitment process is very well established, very well regulated by our HR, human resource, and we hire the most competent people, okay, pharmacists, pharm techs, so that we have a very good team, right? Although we do have trainings, we do have ongoing trainings, but we try to hire the best so that we can, and then we evaluate them on periodic basis. We have our annual review, okay, staffing review, whereby we review and we have our we sit with the staffs and see what have been their challenges, what have been their accomplishment, and what are the things that they need to grow on for the coming year, right? So the training needs are even assessed. We ensure staffing is appropriate. So based on our experience, based on our how our staffing, how our customer care, how our turnaround times are, and how so as not to overwhelm our staffs. What is the correct number of staffing? We calculate and we ensure that we have that number of staffs available for each shift. We have ongoing trainings, right? So in-house and short courses to meet the demands of the institute, right? So as we said, when we were establishing ASP, antibiotic stewardship, we had our staffs on who underwent the SIDP ASP programs of pharmacists. When we had oncology, we had oncology training for pharmacists. Now we are looking into palliative care. So we have 2 pharmacists, one pharmacist who had undergone and another who just underwent a palliative care course. We had pharmacists, we even have a drug information center, I forgot to mention it, whereby in a pharmacovigilance section. So when you're establishing that, again, we had a pharmacist who underwent the training. We have plans to start an extemporaneous compounding, whereby we are going to train a technician to undergo this training and the likes, right? So we have this training happening based on the needs of the staff and more so of the institute, right? We have to align our training and our plans according to the plans of the institute. So whenever the new service is coming up, we get our new staffs trained on them. We have daily debriefings to discuss the previous day and plan for the next day. So every day morning at 8 o'clock, all, be it our outpatient or inpatient, they would be having the different debriefings whereby they discuss the previous day, how was the day, what were the challenges, any reported near miss, medication error, or any achievement or any learning. So we asked our staff, what new did you learn during the course of the day, you know? So they share their experiences. Sometimes they present their whatever presentations we ask them to do, be it clinical or be it operational. Okay, customer care, because we have even patient-centered care going on, whereby we ensure that our staff do our patient-centric, and they even give the best care on a timely manner to our patients. And then we plan for the day. Okay, so based on today's number of patients or what we are supposed to do, how are we going to plan over there? We even have a volunteering program whereby those who are already licensed to practice, they are asked, they can join us, whereby they train themselves, they get the exposure to all the services that we offer, and students as well. But this happens strictly under supervision, because they are not, because as a unit, they're not licensed to practice in our hospital because they're still being trained. So we take them in, we groom them, and train them and expose them. So wherever they end up, at least they've got that necessary exposure. And then we also have an internship program, which we work very closely with the Pharmacy Council, whereby we have interns who have to do their one-year internship. So they come and are here with us. Either others are 6 months, others are 1 year, to spend their time here and finally get and then they get the license to practice, the permanent license to practice. So having discussed all that, what do we see where we need to grow further, right? So what we want to take the pharmacy level, and that has been, I think, even by the ministry, by the Pharmacy Council, by the PST, is to take pharmacy to the next level, whereby we engage more into clinicals, whereby we engage more into pharmaceutical care management or care plan, right? Rather than, it is important to do all other things like storage and the other operational issues. Our cornerstone is our pharmaceutical care plan. So we have initiated from this year, we are piloting in other wards, and to have our pharmacists spend more time and take a lead on a pharmaceutical care plan, which starts from selection of drug all the way to selection, make sure there's timely the administration of drugs, there's monitoring of drugs, there's monitoring of any adverse effects and the likes. So all that is monitored, and the whole pharmaceutical care plan is under the eye of pharmacists in the wards and for outpatient setting as well. Then we are even looking into automating our drug storage monitoring, our electronic health record with clinical decision support that is already on the pipeline. And soon, in the next 2-3 years, we should have that comprehensive electronic health record system. Capacity building of staff, right? We are continuously doing that. We sit with our staffs. They tell us, based on our institute's priorities, what training is required to keep our department up to standards as the hospital is growing. So those are capacity building, be it clinical, operational, customer care. That's how we do continuous capacity building. And lastly, but not the least, is how we can how we can further the antibiotic stewardship within the hospital and even abroad and even beyond, right? So we have our outreach, health facilities. We have our other outlets, okay, small clinics. How do we take it there? Or with other government hospitals as well. We have had such MOUs whereby we even do capacity building for other facilities, so that this antibiotic stewardship is taken holistically and not by our hospital only. Asante sana, thank you. I think I'll leave the floor open for discussion.
Okay, thank you very much, Mujahid, for a very nice and enlightening presentation. I personally have learned a lot from your presentation, provided that I also did my internship at the Aga Khan Hospital in Dar es Salaam. But since that time in 2014, I see there have been a lot of improvement in a very positive direction, and many, many congratulations for that. So members of the symposium, the presentation is now open for questions and discussion. We have about 10 to 15 minutes to do that, and we like to receive your questions. There are two ways of doing it. You can write your question directly in the chat box if you like to ask your question by writing, and we will read it for you. And also you can raise your hand or switch on your microphone and ask it directly here. And I already see the hand of Deogratius Katabalo, and Deogratius, you are welcome to ask your question.
Thank you very much, Nathan Masota. Thank you very much, Mujahidhussein. Indeed, the presentation was impressive. I would like to congratulate your effort and the entire team. I don't have a question, but something which needs clarification. You have done a good job, and I know in doing so you have encountered resistance. So I could like to hear from you if you have encountered any resistance from management, other health professionals, especially doctors, on the implementation of some of these issues, and how do you overcome that? The other thing is, I know usually patients at the hospital pay for medical services. They also pay for nursing services. Is it so for pharmaceutical services? Is it that when you do pharmaceutical services, patient will also pay? Last but not least, how do you see all this achievement? Can it be extrapolated into other hospitals? I mean, can the other hospitals copy from you, or it is only specific for Aga Khan and the likes of Aga Khan hospitals? My question basically needs clarification. Do you see in the government hospitals, public facilities, can we implement these things? What is your advice? Thank you very much.
Mujahid, welcome to answer. Oh, it looks like we have lost the presenter, and I hope he will join soon again to continue with the discussion. Okay. You can unmute yourself, Mujahid, and continue.
Sorry, I think there was an internet connection issue. Yeah, so I got the questions. And the question number one, as per the challenges or obstacles, we are fortunate enough from our management, we did not have any major of challenges in terms of initiating these programs and these services. They were very forthcoming. One challenge that is apart from management, it is to have the right workforce, the right people to do the things, right? And so that has been one thing. So we have to have our human resource and training done. Okay, because you cannot embark on something and whereby you don't have the right caliber of staff with you. So you need, it's not a challenge, but that is something that you need to plan whenever when you're embarking on any such initiatives. Make sure you have planned out your human resource such that you have the right people there doing the competent people already there. From the clinicians, yes, initially when we were starting, when we were starting the ward round, I remember when initially, and I joined in 2008 and 2009, I was very enthusiastic about ward rounds. And when I went to, at that time, when I had gone to the physician there, I had floated this idea just unofficially, by the way, and I could see the resistance that was there, right? But now things have changed, and majority of the clinicians in our hospital are very much, they do appreciate us, and they look forward, and they themselves would call us and ask us for advice. And that is why we had to come up with the Drug Information Center, the pharmacovigilance, and all those departments. We had to come up with it. So on the management, not much, but you see, it has to have. So coming to your second question, now that is where we might have a challenge with it's not a challenge, but it's how you convince the management. You see, whenever you want, you have to have their buy-in, right? So you need to convince them. You need to go with facts. You need to go with figures, right? So that is how you need to work around. So when you're talking about charging, so currently we are not. Okay, currently we are not charging for our. We just whatever because just now the mindset is because all the drugs that we send has a profit already embedded on it. So that is how that is the mindset that is there just now. But as I said, we want to start the pharmacist presence in the ward rounds, right? More prominent. Ward rounds, they are there, but more so, so that they can spend more time in the wards and have a more close interaction with the nurses, the doctors, close monitoring, so that they are involved with the clinical aspect only. We have other pharmacists who do the clinical aspect, the operational or the dispensing. You see, ideally, if you need to have a good clinical pharmacy presence in the hospital, you need to have clinical pharmacists and dispensing pharmacists. Dispensing pharmacists are the ones who ensure that drugs are packed and sent on time, and the clinical pharmacists are the ones who spend and do all the reviews, the medication use review, the reconciliation, and the likes. So we need to have that. So we are trying this, so we are piloting it. Once it matures, once we can sell the idea to the management. So see, this is the value that these clinical pharmacists are adding, is where we can now start proposing the idea of charging like the way the consultants charge, like the way the nursing is charged. The same could come for the pharmacy, but again, it has to be proven, and the system, the services has to be felt by the patient and the management. So that all comes with how you lobby for it. Sorry, can you remind me about your third question?
Okay, thank you. My third question was on the extrapolation of the services you did into other hospitals. Can we copy from you? I mean, Aga Khan is a private hospital, right?
Yeah.
So we are working in the public sectors. So do you think all of the things you did can be implemented in public facilities? What is your advice on that?
Yeah, so my advice would be, you see, the driving force for Aga Khan has been JCIA. Okay? JCIA, when you are accredited, and you have an accreditation body, you'll be audited, you have to give your reports and fine and all. You need, when there is an accreditation system, then it's a whole quality base. So it has to come from the hospital, and it does not only have to be pharmacy. The whole hospital has to have quality agenda as a priority, and And I have heard that there are government hospitals who are already looking into JCIA. And if JCIA is turning out to be very, very expensive, we have even generics of JCIA like self-care, right? So a good step would be even start self-care. You see, when you go with these accreditation bodies, they will come evaluate you and they will tell you your gaps. And they'll tell you, you need to do A, B, C, D, right? Then they will come after 3, 6. And remember, JCIA has been a journey. When did we start? 2010. When did we achieve? 2016, right? It is a 6-year journey. Okay, could have been a bit earlier, but at least it would take 3 to 4 years minimum if you start. So I would suggest the government facilities, self-care is a good option. It's cheaper than JCIA. They are not as stringent as JCIA, so it could be a good starting point. In that way, things get streamlined in all the departments. Because you see, pharmacy cannot have this initiative without having the support from the medical director, from the clinicians, from the nursing, from the dental, from the other departments, from the procurement. It's a team effort. A lot of trainings need to go into it. So my advice would be try to have a quality agenda from the management so that it is then implemented, and it's a journey. And during the way, if you need our assistance, if you need to know what needs our assistance, we are there to assist you.
Okay, thank you very much, Mujahid, and thank you very much, Leo, for asking those questions. And now we have another question from Cliff Benedict, and he's asking how many wards are connected to the pneumatic tube system, and what are the challenges of that system? Mujahid, briefly, if you can.
Yeah, so all wards are connected to the ward, theater, wherever there are medications sent, all of them have pneumatic tubes. The challenge is it's a very sophisticated system, so you need to have the maintenance team who are trained on this, biomedical team ready on this to be ready to troubleshoot or wherever there is a issue of system breakdown. Other challenge is drugs because you input the drugs might be sent to the wrong ward. So you will need to work around that system. But the PTS has solutions to that. So that you can have the capsules program that's for maternity. They'll go directly. So you put the maternity drug in the maternity capsules, and they will go direct to the maternity ward. So such challenges might be there. One challenge that we are facing is the drugs. Once they are sent, how do we ensure that the nurse has received it? There's a slight gap there. Once the drugs have reached there, we are working on how to get that even sorted. So these are things that we learn. Once we initiate, whenever you initiate a system, a process, you will learn along the way. But that doesn't mean that you should not initiate it. Take the leap, take the move, initiate, and you learn along the way.
Okay, thank you very much, Mujahid. We have 4 questions from Ms. Joyce Mosha. Maybe I ask one by one so that you can respond to them. The first one is saying, what lean management tools do you use to identify and prevent waste?
Sorry, what can you come again?
Lean, she wrote, lean management tools. Joyce, if you want to clarify your question, you may do so.
Hi, my question is about the management tools that you use to prevent wastage. For example, in a hospital that I worked previously, we had like the Kaizen and the 5S. And do you also use those tools to prevent waste, or is there any other way that you use to identify and prevent waste?
Waste meaning general waste, all waste throughout the hospital, or are you speaking about pharmaceutical waste?
From
a pharmaceutical perspective, say error in the workflow, for example, to prevent any sort of wastage in terms of, say, medications that are not being used or utilized, or out of stock medications that have not been identified. because of any some sort of maybe organizational skills or anything like that. You have any use and Kaizen very effective in our hospital. So I just wanted to know, do you also use that at Aga Khan, or do you not have that management tool in your hospital?
Yes. So if I got you correctly, one of the ways of managing waste is that the unit dose dispensing system. Okay, whereby so all drugs are sent on 24-hour dosing, and all unused are sent back, right? So we whatever is not used is returned, so that there is no wastage in terms of the drug and bill and financial part as well. The other ways is we always even monitor we know our drug consumption. So we have our reorder levels. We know what are the minimum requirements when we are ordering the drugs on weekly basis, how much to order. So we have that data, and based on that, we ensure there is no wastage. We have our short expiry checks, and we plan. So we know our drugs are going to expire in the next 6 months. So we color code them. So all the drugs expiring within 3 months, they are yellow. The yellow sticker is put on them. Those within 1 month, red sticker is put on them. So all these are initiatives that are done to reduce waste within the hospital. I hope that clarifies the question.
Okay, thank you very much, Mujahid. Maybe for the interest of time, we take one more question from Joyce, and then we will wind up. And the question is on if you use barcode medication administration, or BCMA, for error prevention and administering. Do you have any future considerations on that?
So currently we don't do it, but yes, with the new EHR, we are looking into that modality as well. So currently what is happening is that drug ordering is electronic, the drug processing is electronic, but the drug administration and its recording is still manual, right? The nurses may put it on the administration. But with this EHR, we want to even automate the last process. So automate the medication administration record and look into the possibility of a barcode dispensing system. So as rightly said, it reduces the choice of the wrong drug. And we even have automated dispensing units for outpatient and inpatient, but that would come in the future. For now, at least we want to have this EHR system whereby we can have this administration and the barcode dispensing done.
Okay. Again, thank you very much, Mr. Mujahid, for accepting our invitation and coming to present in today's symposium. We have learned a lot from what you are doing, and you are really doing a good work in the direction of hospital pharmacy, taking very good care of the patient there. And I believe all of us have learned very much, and we are ready to start implementing in our areas of action, in our areas of work, where we work, in all other domains where we can find the knowledge shared today useful. A lot of you have asked for the presentation, and yes, if Mr. Mujahid agrees, we will gladly share the presentation with all of you through the email addresses you have used to register for this symposium. And also, we would like to thank very much our sponsors for this symposium, the Action Medeor and the Christian Social Services Commission of Tanzania. And we also thank all of you for joining. And again, thank you, Mujahid, for presenting. We hope to see you again in our next symposium in the end of the next month. And till then, you can keep following us on our social media, YouTube channels, so that you can stay posted on anything new coming from our side. With that, I would like to end our today's presentation. Thank you very much.